Hello, voice check. Voice check.
Check.
Voice check.
Hello, everyone. Thanks a lot for joining us today. We are back from our summer break, and this is our 30th Journal Club. We're live with Dr. Lydia Dyck today, and she's going to tell us a lot about T cells, obesity, and tumor microenvironment. Dara, would you like to tell our audience about our guest today?
Yeah, absolutely, Jatin. So just to give our audience a little bit of an introduction to our today's guest, Dr. Lydia Dyck. So during her time as a postdoc in Trinity College Dublin, Lydia investigated the effects of obesity on anti-tumor immunity and immunotherapy. Her work demonstrated that obesity suppresses the cellular metabolism and affects an effector function of NK cells and CD8 T cells in cancer models. In 2021, Lydia moved to the Max de Bruck Center for Molecular Medicine in Berlin as a Marie Curie Fellow. So she is currently studying the fate and phenotype of tumor antigen-specific T cells and aims to develop strategies to overcome T cell tolerance. In her free time, Lydia loves to spend time with her family, be active with her toddler twins, and discover the city and lakes around Berlin and play hockey. So thank you so much for spending your Saturday afternoon with us today.
Thanks,
Thanks
Dara,
so
for
much.
that introduction. Lydia, just before I hand over the mic to you, I have one question. You worked in the lab of Dr. Lydia Lynch. Were there a lot of funny moments because you both share the same first name?
Yes. Yeah, I did receive emails I shouldn't have gotten maybe. And
Okay.
there was well, it was called Lydia's Lab, so it was kind of applied to both then.
Yep. All right. Without any more delay, I'm going to hand over the virtual mic to you so you can tell us about your recent work in Journal of Experimental Medicine.
Yeah. Thanks so much for inviting me and also for the kind introduction. Just going to share my screen. So I hope this is working now. Yeah. I will, for this journal club, present the paper that we published in February this year, which was the research topic of my postdoc in Trinity College Dublin, when I was working in Lydia Lynch's lab, and I investigated the effects of obesity on CD8 T cells in cancer models. So just to start with the general introduction, so obesity is a global health problem that affects the whole world by now. And just to give you an idea how widespread it is, so obesity is overweight is defined of a BMI of over 25, and if it's a BMI of over 30, a person is considered obese. And the statistics show that in Europe, for example, almost 60% of the adult population over 20 are either overweight or obese, and in general, in total, it's also over 20% that are obese. In the US, the statistics are even worse. So the prevalence of overweight or obesity is over 70% already. The prevalence of obesity is 40%. So that's a huge problem. And also childhood obesity is increasing, and children that are already overweight or obese in the early years have a high risk of also being obese or overweight when they're adults. And the biggest problems with obesity are the comorbidities that it can cause. So you probably all know that obesity can cause type 2 diabetes or heart disease, but it's also associated with other diseases such as osteoarthritis, hypertension. And we're really beginning to understand that obesity is also a huge risk factor for cancer. It actually is, according to latest studies, the second the second highest risk factor for cancer after smoking, and this could even change the next 10 years, and obesity could overtake smoking as the #1 risk factor for cancer, because there are less and less people smoking, but the rates of obesity are increasing. And to date, 13 types of cancer have been shown to be associated with obesity. And the cancers with the highest link, strongest link to obesity are, for example, pancreatic cancer, where 28% of the cancers are linked to overweight or obesity. Then esophageal cancer has also been linked to obesity, and endometrial cancer has really the strongest link to obesity, with almost half of the cancers being linked to obesity. And endometrial cancer is the cancer of the inner lining of the uterus. And so a lot of different mechanisms have been studied and identified how cancer and obesity are linked. I'm just going to give you an introduction of several of those. And a lot of the links are direct effects of obesity on the transformation of normal cells into cancer cells and the growth of tumor cells. For example, in obesity, there's this change in adipose tissue, and it's really large mass of the adipose tissue. And in obesity, this can lead to this really increased release of hormones, and such as estrogen or growth hormones, but also insulin and adipokines. And all these hormones have in common that they can promote the growth of cells, which is one of the hallmarks of cancers, if there's this never-ending proliferation of cells. Other mechanisms include, for example, the lipid uptake and lipid metabolism in normal cells, but also in transformed cells. So studies have shown that the uptake of this increased uptake of lipids in obesity, for example, in mouse models, and then this can lead to the transformation of normal cells to tumor cells, but lipid uptake and metabolism can also promote the proliferation of cancer cells and metastatic potential. Another link between obesity and cancer is this metabolic dysregulation of tumor cells in obesity, and it has been shown, for example, that AMPK is downregulated and mTOR can be upregulated, and this has, as a consequence, a much higher metabolic rate and proliferative potential of tumor cells. And another big link between obesity and cancer is this chronic inflammation that you see in the adipose tissue, and this constant infiltration of pro-inflammatory immune cells and secretion of pro-inflammatory cytokines. So this chronic inflammation can also lead to the transformation of normal cells to tumor cells, and also drive the proliferation of cancer cells. So these mechanisms have been described in the past, but a field that hasn't been studied that well to date is the link between obesity and anti-tumor immunity, such as natural killer cells. And what I'm going to talk about today is the link between obesity and the immune response elicited by CD8 T cells, and how they control tumor growth. So CD8 T cells, there are known killers of cancer cells, and they can kill cancer cells when they recognize, if they're primed properly in the periphery, and also when they recognize this specific antigen presented by cancer cells. So it's a specific immune response against the cancer. So we studied how this interaction and the elimination of cancer cells is affected by obesity. And for this, we worked with a mouse model where we used a standard fat diet or a high fat diet that we fed the mice. So from the standard fat diet, the mice get 30% of the calories from fat, whereas from the high fat diet, it's 60% fat. So after around 2 months, you can really see the significant changes in body weight. So once the mice became obese in the high fat diet group, we injected tumor cells subcutaneously under the skin of the mice, and then we investigated how obesity affected the tumor growth, and also analyzed the T cell responses in the periphery, and especially in the tumor microenvironment. So first of all, we used 2 different tumor models, the B16 melanoma cell line and the MC38 colon carcinoma cell line. And we measured the weight gain of the mice, but also the tumor growth. So first of all, we saw that over time, the high-fat diet fed mice gained significantly more weight than the standard fat diet mice, which is expected because they have become obese after around 2 or 3 months. And then we saw that the high-fat diet in the high-fat diet fed mice, the 2 tumor cell lines that we injected, they each led to enhanced tumor growth when the mice were on a high-fat diet. So showing that high-fat diet enhances the progression of the tumor development. And we next looked at the infiltration of the tumors in both tumor models by immune cells. So first of all, we noticed that in both tumor models, there's a significant decrease of infiltrating total leukocytes, so all immune cells. There's less immune cells in the tumors, but we also saw a significant decrease in the infiltration of CD8 T cells, a decrease in infiltration of CD4 T cells only in the B16 model, and a decrease in infiltration of NK cells. We next had
Lydia, I had just a technical question. I don't work with tumors, so when you look at tumor infiltrating lymphocytes, do you take out the tumor, grind it, and run it through flow?
Yes, exactly. So yeah, we dissect the tumors and then we digest the tumor until we get a single cell suspension. So we still have all the tumor cells and the immune cells in there. And then with the antibody staining, we can then distinguish the immune cells and their phenotype. Yeah. Yeah, so next we had a closer look at the infiltration of the immune cells into the tumor. And we used this technique of intravenous staining of immune cells. So what we did is we took a CD45 antibody, which stains all leukocytes, which was fluorescently coupled to PE. And we injected this antibody intravenously. And then we waited 10 minutes before we culled the animals. And what happened with this intravenous injection is that this antibody stained all the immune cells in the circulation, also in the circulation within the tumor, but all the tissue resident immune cells were not stained. So then when we dissected the tumors and then we did flow cytometry on them, and we had a look at immune cell infiltration, we see 2 populations. So there's one population that is stained for the CD45 antibody that we injected. So these are the cells that are in the circulation in the tumor. And then we have the CD45.2 negative population, and these are the tissue resident immune cells. So then with this technique, we could distinguish, we could have a look how well the immune cells infiltrate the tumors. And what we saw comparing the standard fat diet versus the high fat diet mice, that the proportion of tissue resident cells is significantly decreased. So if you look at total immune cells, there's this decrease of the tissue resident population in the high fat diet. And just looking at CD8 T cells, we see also a significant decrease in infiltrating CD8 T cells, suggesting that there is an impairment in the CD8 T cells crossing the blood and getting into the tumor tissue. So we next looked at trafficking molecules. So for CD8 T cells to get to the tumor and also to get from the blood vessels into the tumor tissue, chemokines and chemokine receptors play an important role. So we looked at some of the important chemokines involved in CD8 T cell recruitment to the tumor, which are the chemokine receptor CXCL3 and the corresponding chemokines CXCL9 and CXCL10. And for all of these, we saw that in the high-fat diet-fed mice, we have a decrease of CXCL3 expression on CD8 T cells, and also the levels of CXCL9 and CXCL10 were decreased in the tumors of high-fat diet-fed mice, suggesting that the high-fat diet and the obesity that results from the high-fat diet suppress the immune cell trafficking and infiltration. So having shown that there's less CD8 T cells infiltrating the tumors in the high-fat diet, we next looked at the phenotype of the CD8 T cells that do get into the tumor. And also there we saw striking functional changes. So we found that the cells that infiltrated the tumor were defective. So they produced less interferon gamma. We also saw a reduction in the interferon gamma TNF positive population. So this is kind of the phenotype of the activated CD8 T cells that are able to kill tumor cells. They also produce less granzyme B in the high-fat diet, and granzyme B secretion is one of the mechanisms by which CD8 T cells can kill tumor cells. And we also see a reduction in the expression of Ki67, which is the proliferation marker. So overall, we see this dysfunctional phenotype of CD8 T cells in the tumors of the high-fat diet. And anyone working with those subcutaneous tumor models will probably know that. So if you have the tumor and when the tumor grows in size over time, you see that the tumor size itself affects the phenotype of the immune cells. So in general, it doesn't matter which model you use. So the bigger the tumor gets, the less functional the T cells get. So you naturally see this decrease in interferon gamma production by CD8 T cells. So this can be a problem when you're comparing large tumors in one group to small tumors in another group. So this could just be just down to size differences of the tumors. So we wanted to see whether this defect is just because we have bigger tumors in the high-fat diet, or whether there are also high-fat diet-induced functional differences. So we did is we proved some experiments and compared tumors of the standard and high-fat diet that were had the same size. But so even tumors at the same size, we saw that interferon gamma production was lower in the high-fat diet fat mice compared to the standard fat diet. And we saw that for the B16 and the MC38 model. So the differences that we see are not just down to comparing tumors of different sizes. So then next we wanted to investigate the mechanism behind these functional defects that we see in CD8 T cells. So first of all, we looked at the peripheral activation of CD8 T cells. And so the first simple experiment that we did is we fed mice with the standard fat diet and high fat diet. And we wanted to see, can we even activate CD8 T cells that we isolate from high fat diet fat mice, or other general defects after the high-fat diet. So we stimulated the CD8 T cells in vitro or ex vivo, and then we did a seahorse analysis to see to investigate their cellular metabolism, so the rates of oxidative phosphorylation and glycolysis, and we also looked at the secretion of effector molecules and other activation markers. So when we just looked at the splenic CD8 T cells from standard fat and high fat diet mice, we don't see any differences. So we could activate them to the same extent as the lean CD8 T cells. So we had no differences in cellular metabolism when we had the same levels of interferon, TNF, granzyme B production, and the expression of CD69. So peripheral CD8 T cells from high-fat diet mice can be activated in vitro. And next we had a look at the draining lymph nodes in tumor-bearing mice, because this first experiment was just the high-fat diet and standard fat diet without the tumors. So we looked at the CD8 T cells in the draining lymph nodes, where the T cells get primed before they get to the tumor. And the same, we didn't see any differences between the standard fat and high-fat diet fat mice. So so all the levels of interferon gamma, the proliferation and activation marker expression were not significantly different. They were even slightly, there was a trend towards elevated activation in the lymph node. So these findings suggest that, that there might not be an impairment in peripheral CD8 T cell activation. So based on these findings, we then focused on mechanisms inside the tumor that could lead to this dysfunctional phenotype of CD8 T cells. So the first thing we looked at was T cell exhaustion. So we were wondering, do immune checkpoints play a role? Because it's known that when T cells get activated, but also especially when they're in the tumor microenvironment, they largely upregulate immune checkpoints, including PD-1, and the engagement of these immune checkpoints, of these inhibitory receptors, leads to T cell dysfunction and exhaustion. So we're wondering, is this maybe affected by the high-fat diet? Or is this the mechanism by which high-fat diet promotes T cell dysfunction? So we first looked at PD-1 expression, and we also did this IV staining. And first of all, we saw in both high-fat diet and standard fat diet mice that the PD-1 expression in the circulation is rather low. It's really just once the T cells enter the tumor, this is when they start expressing PD-1. But then comparing the standard fat diet and high-fat diet mice, we didn't see any differences in PD-1 expression. But in even looking at the levels, even in the standard fat diet mice, there's already around 90% proportion of CD8 T cells express PD-1 already. So there's no room really to upregulate that. We then looked at the expression of PD-L1. So PD-L1 is the ligand for PD-1. So we were wondering maybe there's a higher expression of the ligand, and this is why we see more suppression of CD8 T cells. So we looked at immune cells and non-immune cells. So on immune cells, we didn't see any differences between standard fat diet and high fat diet. And on the non-immune cells, which are stromal cells and tumor cells, we even see less expression of PD-L1. So since PD-1 and PD-L1 were not significantly altered, or this doesn't explain this dysfunction that we see, we looked at other immune checkpoints. And for all the checkpoints that we looked at, we saw that compared to the lymph nodes, immune checkpoints are really strongly upregulated once T cells enter the tumor, but there were no significant differences in expression of the checkpoints LAG3, TIM3, or TIGIT, or 2B4. So obesity does not increase the expression of immune checkpoint receptors. So next we looked at the lipid uptake of CD8 T cells, because in our previous work, we looked at NK cells, and this is another publication from a few years before that. And we looked at NK cells from lean and obese mice, but also from patients and from donors. And what we found is that in obesity, NK cells take up neutral lipids, and we see these lipid accumulations inside those NK cells. So this is the fluorescent staining, and you can really see those lipid droplets inside NK cells. And what we found is that this lipid uptake and accumulation in NK cells, so they're loaded with lipids, and this causes this metabolic dysfunction in NK cells, and is linked to functional defects in NK cells. So then we looked at lipid uptake by CD8 T cells in our tumor model, and what we actually found was the opposite to NK cells. So we did the staining for lipids inside the T cells, and we saw in the high-fat, high-fat mice, we actually have lower levels of lipids, which we measured by lipid tox. And we even saw that when we looked at the correlation between the lipid levels in CD8 T cells and the tumor volume, that as the tumors get bigger, CD8 T cells have lower lipid content. And when we look at the lipid tox levels against the production of interferon gamma, the high lipid levels in CD8 T cells correlate with the functional phenotype. So it looks like lipids are required for CD8 T cells to be active. And in obesity, we actually see a reduction in lipid levels. So we didn't follow up more on this, but this kind of showed us that the lipid uptake doesn't seem to be the mechanism that's causing CD8 T cell dysfunction the way it does in NK cells. So then we kind of took a step back and looked at general effects of obesity and the high-fat diet on the systemic metabolism in the mouse. So we did metabolomics in collaboration with Ivana Mills and Hannah Prenville. And so we did metabolomics on the serum of standard fat and high-fat diet fat mice, and looked at the abundance of different metabolites, and did this analysis to see whether there are different levels of different metabolites between the standard fat diet and high fat diet, and we see that the abundance of the clusters within which the mice fall are completely separated between the standard fat diet and high fat diet. It suggests that the abundance of different metabolites is completely changed in a high fat diet. And then just looking at all the amino acids, we also see there's two completely separate clusters between the standard fat and high fat diet, suggesting that the amino acid composition in the high fat diet is completely changed. And one amino acid that really stood out to us was glutamine, because we saw a decrease in the levels of glutamine in the high fat diet in relative to the standard fat diet. And so anyone using tissue culture medium probably knows that you have to add glutamine for T cells to be able to activate them. So glutamine is really one of the most important amino acids for CD8 T cells. So in absence of glutamine, you can't activate the CD8 T cells. And once you add glutamine to the culture medium and you activate CD8 T cells, only then they start to proliferate and produce interferon gamma. engram B and upregulate their cellular metabolism, which we measured by the phosphorylation of S6. So because we saw these changes in systemic metabolism and nutrient abundance in the mice, we then focused on the cellular metabolism of CD8 T cells to see whether there's a link, because cellular metabolism is intrinsically linked to effector function of CD8 T cells. So I'm just gonna talk you through what actually happens inside a CD8 T cell when it gets activated. So when a T cell gets activated through the TCR and the co-receptor CD28, this causes the activation of the transcription factor MYC, but also mTOR is activated, and these two are really essential for proper CD8 T cell function. And downstream of those, this leads to metabolic reprogramming of the CD8 T cells. So an activated CD8 T cell strongly upregulates glycolysis and generates ATP through glucose, but the glycolysis is also needed to generate intermediates for nucleotide synthesis and other building stones of amino acids or fatty acids. But activated CD8 T cells also increase in oxidative phosphorylation. So this is another pathway by which they generate more energy. And for CD8 T cells to get properly activated, it's really important for them to take up amino acids such as leucine. And leucine is taken up through the amino acid transporter SLC7A5, and it's, for example, required for nucleotide synthesis, but also it's required for the proper function of mTOR and MYC. So in the absence of leucine, you don't see this activation or metabolic reprogramming. So we had a closer look at the transporter SLC7A5. So SLC7A5 is actually an antiporter, and to take up amino acids such as leucine, it needs to export glutamine. And Linda Sinclair in Dundee from Doreen Cantrell's lab, she developed this really nice assay to measure the activity of this transporter SLC7A5, and she showed that another metabolite, kynurenine, it's innately fluorescent, so this can be used as a stain for the activity of SLC7A5, and kynurenine is taken up through this through SLC7A5 as well, so we can use that as a flow cytometric measurement of the activity and expression of SLC7A5. So next, we used this assay that Linda Sinclair developed to see, to look at the amino acid metabolism of CD8 T cells in the tumor. And indeed, we found that in the high-fat diet, the uptake of kynurenine was significantly reduced, suggesting an reduced activity of SLC7A5. And we also looked at the phosphorylation of S6, which is downstream of mTOR, as another marker of cellular metabolism activation of CD8 T cells. And also here we saw a significant decrease in the phosphorylation of S6. And then just to show again that amino acid uptake through SLC7A5 is actually linked to function, we saw when we plot the uptake of kynurenine against the proliferation or against interferon gamma expression, you see that there is a strong correlation that the higher the uptake of the activity of SLC7A5, the more they proliferate and produce interferon gamma, and this is completely abrogated in high-fat diet fed mice. So having shown that that there are really significant effects of the high-fat diet and obesity on the activation of CD8 T cells, we were then interested so whether this has any effects on immunotherapy, because for immunotherapy to work, you need to be able to activate CD8 T cells. For example, checkpoint blockade relies on the activation of CD8 T cells. So this was then our next research question. And over the last 10 years, there's really been a change in the treatment landscape of a lot of cancer because of new immunotherapies that entered the market. So it was 11 years ago, the first immune checkpoint inhibitor was IPI was approved for melanoma, which is targeting CTLA4, but shortly after other immune checkpoint inhibitors like pembrolizumab or nivolumab against melanoma were approved, which are antibodies against PD-1. So really, if you look at this, these are the different approvals for the different checkpoint inhibitors, especially antibodies against PD-1 or PD-L1 have now been licensed for a lot of different types of cancers. And there are also more and more different antibodies being approved for cancer therapy. And they're also the first line therapy for several types of cancer. And the way PD-1, for example, works is it's expressed on activated and exhausted T cells. And if PD-1 binds to its ligand, PD-L1, this has a lot of downstream effects on CD8 T cells. For example, it suppresses the downstream signaling of the T cell receptor, like PI3 kinase and mTOR signaling are impaired by the ligation of PD-1. But it also has metabolic effects. For example, PD-1 ligation decreases the rate of glycolysis and enhances fatty acid oxidation. So it causes a metabolic reprogramming in CD8 T cells, which as a result leads to reduced effector function, proliferation, and cytotoxicity of CD8 T cells, and then in the end causing T cell exhaustion. And so we wanted to see, so this can be reversed then by using a anti-PD-1 antibody. And we wanted to see whether this therapy still works in a context of high-fat diet and obesity. So for this, we used the MC38 tumor model. And the reason we chose this model is because it's been shown previously that it's sensitive to PD-1 therapy. So you can actually cause rejection using an anti-PD-1 antibody in this model. So our mice were fed with a standard fat diet and a high-fat diet. And then once the mice were obese, we injected the tumor cells, and then the mice got 3 doses of this anti-PD-1 antibody. And then we had a look at the tumor growth in these mice. So first of all, if you compare the black with the red group, again, we saw this really strong increase in tumor growth when the mice were fed with a high-fat diet. But much to our surprise, at the time when we did these experiments, it didn't matter if a mouse was on a high-fat diet or a standard fat diet. We really saw this complete rejection of the tumors independent of what the diet was. So the anti-PD-1 therapy still worked. And then we re-challenged the mice that previously rejected the tumors to see if the mice had a functional memory response and would recognize them again, so they didn't receive any further therapy. We just re-challenged them with the same tumor cells. And again, we saw that the mice that previously rejected the tumors in both standard fat diet and high fat diet, again, rejected the tumor cells that we then injected, which suggests that there is functional memory in the high fat diet fat mice. And next, we looked at the phenotype of CD8 T cells and we're wondering what happened to them in the standard fat and high fat diet setting. But because we saw this really rapid rejection of the tumor cells, it was quite difficult to actually be able to get tumor mass to be able to analyze CD8 T cells. So we changed our injection and therapy regime. So again, the mice were on a standard and high fat diet and then got the tumor cells. But instead of starting early therapy, we waited until the tumors were bigger, and then they only received 1 dose of the anti-PD-1 antibody. And then 2 days later, we looked at the infiltration of CD8 T cells and their phenotype. And we saw that after only 2 days after the one injection, so this is before the tumors were rejected, that the anti-PD-1 therapy restored some of the defects that we previously saw in the high-fat diet. So we see this restoration of proliferation of CD8 T cells. There's this increase in expression of Ki67. We see a slight increase in granzyme B production, but no differences in interferon gamma. But very strikingly, we see that the uptake of kynurenine was significantly increased after anti-PD-1, which is a sign for SLC7A5 activity. So the amino acid metabolism seems to be quickly restored after anti-PD-1 therapy. So this suggests to us that even though the high-fat diet has these suppressive effects on CD8 T cells, these defects can be overcome and restored through anti-PD-1 therapy, and that immune checkpoint blockade is still effective in the setting of high-fat diet. And this is in line also with some clinical trials that have been done in the past, and around the same time, there was this paper published that looked at the effects of obesity on the outcome of immune checkpoint blockade in melanoma patients. And they saw these paradoxical effects. So they looked in this study at, they stratified the patients based on their BMI. So they had the normal BMI group, the people that had overweight and people with a BMI of over 30, the obese cohort, and they looked at their response to immune checkpoint blockade, and they found that the patients that were either overweight or obese actually responded better to immune checkpoint blockade. And similar results have now also been shown for other types of cancer, that the obese and overweight patients seem to respond better to immune checkpoint blockade, which is kind of termed the obesity paradox. And mechanistically, yeah, this is still a field of study. So a lot of researchers are now trying to figure out how this obesity paradox can be explained. But melanoma, this study was a melanoma, so melanoma is not typically linked to obesity. So we teamed up with a clinician, with a surgeon in St. Vincent's Hospital in Dublin, Professor Donald Brennan, and he was working with patients that had endometrial cancer. So we wanted to see how does obesity affect the immune infiltration in tumors of a cancer type that is actually linked to obesity. So we analyzed biopsies of endometrial cancer patients that had different BMIs, and we looked at the infiltration and the abundance of CD3, so total T cells, and also of CD8 T cells specifically. And as you can see, this is a person with a BMI of 26 compared to a person with a BMI of 46, is just one example, but there's this really deserted phenotype in the person with this with a strong obesity compared to the infiltration in this person with a lower BMI. But so this is just two patients, but then we had a larger cohort that we investigated, and we looked at the correlation between the BMI and the infiltration of CD3s or CD8s. And again, we saw that BMI negatively correlates with the infiltration of CD3s and CD8 T cells. So we see this decline in immune cell infiltration, the bigger, the higher the BMI. And so for cancer patients with endometrial cancer, so especially for the ones that are obese, something that's done in the clinic typically is this vertical sleeve gastrectomy, also because the tumors aren't always accessible because of this, because of the anatomy and the large fat tissue. So this is why this vertical sleeve gastrectomy is often done on patients with endometrial cancer. So what happens is bariatric surgery or metabolic surgery, it's also called. So what's done is that a part of the stomach is being removed of these patients. And then after 3 and 6 months, they saw that the patients start losing weight because of this smaller stomach size. So they very quickly lose a lot of weight. And what they found is that, so this is a cohort of 9 patients now, that just after this bariatric surgery, without any further chemotherapy or other therapies, they saw this complete pathological response. So the tumors were shrinking, they were being rejected in 6 out of 9 patients, and only one patient showed progressive disease, and 2 patients had stable disease. So just weight loss alone in these patients was able to induce a pathological response in endometrial cancer. And through our collaboration, we had access to one patient, luckily, where we could analyze the infiltration of the tumors with immune cells before and after the surgery. And so we looked at the immune cell infiltration before the surgery, and so there were very few immune cells in there, and then we had different time points. Where we had biopsies that we could stain for immune cell infiltration. We saw as the patient was as the patient was losing weight and the tumor was reducing in size, we saw this increase in immune cell infiltration. And of course, it's just one patient, but this is something that's been being followed up, whether the weight loss actually leads to increased immune cell infiltration and whether this is linked with the shrinkage of the tumor. So to summarize the findings of our paper, so it's been known before that obesity can lead to cancer transformation and proliferation through the secretion of growth hormones and other hormones and insulin. However, we could show that obesity also suppresses the anti-tumor immune response of CD8 T cells. We saw a suppression of proliferation, effector function, metabolism, and infiltration. However, using immunotherapy with an anti-PD-1 antibody, we were able to restore CD8 T cell effector function, and we saw this rejection of the tumors. And in the clinic, this has been described. There has been this obesity paradox where obese patients responded better to anti-PD-1 therapies, and also we saw that in an endometrial cancer that the weight loss can lead to tumor rejection. So yeah, this is the paper if anyone wants to read it and have wants to know more about it. And I also want to thank everybody involved with this study. So everybody in the Lynch Lab that contributed and helped me with the project, and also the Lynch Lab in Harvard, and our collaborators in Trinity College, such as David Finley and Kingston Mills, and especially our clinical collaborators, Donald Brennan, and everybody involved. So this is the paper, and I'm happy to answer your questions now.
Thanks a lot, Lydia, for the wonderful talk. I had a question. You showed first that there is a difference between the infiltrating T cells with high fat diet and the standard fat diet, but when you treat them with anti PD-1, the tumor volumes, they become equal. So is the infiltration of T cells the only factor that's separating the high fat diet and the standard fat diet phenotype with respect to tumor?
You mean before or after the therapy?
After the therapy.
So we saw differences, like a few differences. So we only had this really small window to look. So I think it was just one time point. So I think other markers might change at different time points later on as the tumors are actually being rejected. So this is we were only able to look 2 days after the therapy. So these are the early markers that we think have been changed. And yeah, we saw difference in proliferation was the first one, and also in carnitine in amino acid metabolism and granzyme B, we saw differences as well. So there's also functional and metabolic markers that we saw increased after anti-PD-1 early on.
And regarding leucine uptake, I know you said about the fat uptake that the CD8s they took up less fat than with the high fat diet. Do you think is there any relation between leucine uptake reduction and the fat uptake reduction? Like, have you looked at? Do you think it's like something expression about CD36 maybe, so they're not able to take up these long chain fatty acids?
Yeah, we looked at CD36 expression, and we actually didn't see any differences in our experiments. But there has been a publication also using similar models to us from the labs of Arlene Sharp and Marsha Haggis. I'm not sure if you've seen them. And so they actually also saw this decrease in fatty acid uptake. And it looks like it might be also one of the mechanisms that suppresses CD8 T cells in the high fat diet tumor microenvironment, that they might not be able to take up fatty acids. And this is one of the ways that the function is also suppressed. Yeah.
Okay. Just want to make sure. Are there any other questions?
Oh, yeah, BJ.
Thank you for the talk. It was quite interesting. My question was also like kind of relating CD8 infiltration in general scenario and obesity. I mean, the scenario is mostly type 1 diabetes, and if if this obesity and this infiltration into the pancreas is kind of relatable, and you know, what's your insights on that?
Can you repeat, please?
No, I was just curious about the relationship between obesity and the CD8 T cell infiltration during type 1 diabetes
Mm.
in the
So
pancreas.
yeah, pancreas, I'm not sure now. So it's a few different things. So definitely people with type 2 diabetes also have increased cancer risk. And in pancreatic cancer, it's actually quite fatty cancer. So there's been a study recently been published that showed that the high levels of lipid are actually suppressive to CD8 T cells in pancreatic cancer. So there's definitely a link there as well. And I mean, CD8 T cells are probably are also linked to diabetes in different ways. So, for example, after immune checkpoint blockade, one of the main immune-related adverse effects is the development of type 2 diabetes. It's actually very common that patients on anti-PD-1 therapy do develop diabetes. So, yeah, they're all linked, I'd say, in different ways. Yeah.
Yeah. Also, the reason is like recently I came across finding which they showed that like, in general, people with type 2 diabetes have a lower risk of aneurysms. It was surprising because I mean, aren't there? Isn't it supposed to be in general? People with type 2 diabetes, either it's genetic or it's a lifestyle, and they were, at least to my knowledge, I used to think they had a higher risk of suffering aneurysms. But it's the other way around apparently. And do you think immune cells may have to play a role in this in general?
In aneurysms,
I mean, just an idea.
yeah, so that's I can't really say anything about that.
Yeah.
I haven't heard anything about this. Is a bit too far out of my vision at the moment, what I'm looking at. It's definitely interesting. I think in general, the immune system plays a role in a lot of things that we are not appreciating yet. It's not just defense of viruses and bacteria. It also, the immune system plays a role in a lot of the homeostasis that we see. Especially for in the adipose tissue in general and energy generation. So there's a lot of homeostatic roles for the immune system that we're probably not appreciating yet, or yeah, I'd say in the future we will know a lot more about that.
Yeah, thank you. Because yeah, as you mentioned, in the adipose tissue, I did come across this paper where they said that macrophages kind of break down the excess norepinephrine and they kind of maintain the homeostasis in the adipose tissue. Right?
Yeah, exactly. Yeah.
Thank you.
Yeah, one more question, Lydia. That this paper was a lot of work. How how many years did it take to get all of this done? And I see you have collaborators, intercontinental collaborators. So like collecting the data and working on those.
Yeah, so I was in the Lynch lab before I went on maternity leave. I was 4 years. So we started off with the NK cell story, and so we did all the high fat diet experiments looking at NK cells, and from that I then moved in started looking into CD8 T cells as well, and doing the different immunotherapy experiments. So 3 to 4 years, I'd say for sure. And yeah, we collaborated with people in Trinity a lot and with clinicians. With Donald Brennan in the clinic, and then also we worked very closely with like the second arm of the lab in Harvard and the people there. So yeah.
It's a lot of work and it's quite interesting. Like you have a lot of open ends, so you can pursue them after this. So what's your plan for the future of the study?
So there are other people that worked on similar things in the Lynch lab. So for example, Hannah Prendeville was looking at different types of diets, and so whether it makes a difference in whether the source of fat makes a difference on how the immune cells respond and how active they are against the cancer. So the Lynch lab, they are looking at different avenues, coming from this. I have since changed the labs. I moved to Berlin, and I'm not working on obesity at the moment. So it's a lab that works with different types of cancer models that grow a lot slower over a year. So in the future, what I would like to do is looking at the effects of obesities in tumor models that are much more resembling the development of cancers, similar to humans, where you have this really, so you start with the mutation that then slowly develops into tumor. And I would, like to investigate the effects on CD8 T cells, in those models, and look more at metabolism over a kind of longer period of time. But also I'm interested in the peripheral activation of CD8 T cells and how that's affected by the high-fat diet. I think this is just something we only had a small look in our study, but I think there's a lot more that we can look into. And I think the general priming of CD8 T cells and CD8 T cell activation is not only important for the immune response against cancer, but also for the immune responses against viruses, bacteria, and how that's affected by obesity, especially now with COVID and vaccinations. I mean, this affects a lot of things, and the effects of obesity on CD8 T cell priming, I think, is an interesting field where there's a lot more to learn still.
Yeah, you bring up a good point about the activation of T cells being important for infections. Do you, just off the top of your head, do you know if there's any correlation between BMI and response to COVID?
Well, yeah, I mean, I think it's quite well known now that obesity is a risk factor for severe complications in COVID. Yeah.
Okay. All right. Assuming there are no other questions, thanks a lot, Lydia, for joining us today, giving us your Saturday afternoon.
Thanks so much for inviting me.
It was really nice talking. And for everybody watching this right now or later, the video will be uploaded on Facebook it takes about 24 hours for the whole processing, and it'll be available for watching later. And thanks a lot for everybody for being here, and we'll see you next month for our next journal club. Thanks a lot, Lydia, and you may stay after we end the session. Okay. All right. Bye bye. See you guys next time.